Welcome everyone. My name is Jennie Brentnall and I'm an occupational therapist and lecturer in work integrated learning at the School of Health Sciences at the University of Sydney. I'll be chairing this morning's session from the lands of the Darug and Gundungurra peoples. So continuing on the topical theme from this morning's very engaging keynote, the session you've joined now is a concurrent session on preparedness, health responses to COVID-19. So we have 3 presentations and we're going to hold all the questions to the end of the session. So you can use the Whoever app, click the Ask a Question button and post a question there, and we'll address them all as a panel at the end. I'm going to introduce our first speaker, Melissa Ciardulli. Melissa is a very experienced paediatric intensive care nursing worker and is the current simulation program leader at the Faculty of Health Sciences Youth and Community Studies at Holmesglen Institute in Melbourne. So welcome, Melissa. You just start sharing your screen, and I'll have our other presenters stop their video, please.
Great, thank you. Okay, I just wanted to check that you can see the screen.
That's perfect, thank you.
Perfect, great. Okay, so hello and welcome from Melbourne, where it is currently raining. And my presentation today within the category Preparedness, Health Responses to COVID-19. So my title today is Ella Does Not Like Needles, Simulated Participants Making It Real. And firstly, I would like to thank Laurel and Jennie for sharing today and look forward to sharing this session with Greg, Anne and Philip. Before I begin, I would like to acknowledge the Wurundjeri people who are the traditional custodians of the land I am on today. And I would also like to pay my respect to the elders, both past and present, of the Kulin Nation and extend that respect to other Indigenous Australians present. So a little about where I work to provide some educational context. Holmesglen is a leading Australian provider of vocational and higher education, having close connections to the community and industry and upholding strong values of ambition, scholarship, passion, integrity, respect and excellence. Within the Faculty of Health Sciences, Youth and Community Studies, there are 7 diverse course areas. And as academic lead across the faculty, part of my role is to facilitate the use of simulation-based education, which I'll abbreviate to SBE from now on for ease of purpose and saving valuable seconds. This facilitation occurs using evidence-based conceptual frameworks, working with colleagues across all departments, simulated participants, industry, and a simulation community of practice across the faculty. Within my faculty, Holmesglen offer a Certificate 3 in Pathology Collection. This is a nationally regulated training course consisting of 20 hours per week for 5 months, plus a 35-hour clinical placement in a pathology collection department, with learners graduating to work in the pathology sector. So I think that we are all acutely aware that COVID-19 has really rocked our healthcare systems across the world, increasing the pressure on and expectations of our healthcare workers. So phlebotomists have played a pivotal role throughout the pandemic, and blood and pathology collectors, who apart from their normal workload, apparently conducted approximately 31 million COVID-19 tests through a mixture of public and private pathology labs across Australia. The pathology collection industry, however, is certainly navigating uncertain futures, with a nationwide shortage of pathology collectors being experienced throughout Australia. The government's recently listed the course on a new job trainer scheme to subsidise fees and attract new learner interest. However, with employment of pathology collectors and phlebotomists projected to grow much faster than the average for all occupations, pathology collectors are entering uncharted waters. The added burnout rate and compassion fatigue as the pathology industry deal with members of the public in a heightened emotional state due to the pandemic has no doubt contributed to this mass shortage of workers. So recent research has identified effective communication skills as a key to success during pathology collections. However, the skills only briefly touched on during their course. So it seemed fitting to create an immersive simulation for pathology collectors and learners that focused on communication skills to prepare them for entry into the workforce during a COVID-19 pandemic, contextualising their theory, skills and concepts they've been learning before heading to placement and employment. So here is my completed novel. I hope you enjoy it, titled Ella Does Not Like Needles, a story of how simulated participants were successfully integrated into an allied health program. So as you know, I'm Mel Ciardulli, and this is the first public reading of Ella Does Not Like Needles. My background is in paediatric intensive care nursing, where I began my passion with simulation, working with technology-dependent high medical needs children to discharge them back to their home environment. From clinical beginnings, I migrated across the world of higher education, then vocational learning, before completing a full circle and landing back into my original domain of healthcare simulation. With most stories, I'd like to commence with a dedication to the simulated participants, casual employees of Holmesglen who work with the students in immersive simulated scenarios and OSCEs. Our SPs portray patients, family members, clients or professionals in the clinical scenarios, providing real, authentic and opportunities for our learners to incorporate their clinical skills and knowledge with communication, empathy and cross-cultural sensitivity. We know research has highlighted the effectiveness of simulated participants or simulated professionals, as it was unanimously decided in one of yesterday's sessions, working with healthcare learners. And that by practicing their skills with SPs, learners have the opportunity to develop and refine their interpersonal skills and professionalism in a safe environment. I'd like to express thanks to the following for their support and contributions. Professor Deborah Ciardulli, who's a clinical chair, health, workforce and simulation at Holmesglen Institute. Lisa Houston, a teacher of allied health services and science, and a simulated participant program at Holmesglen. So simulation-based education at Holmesglen's widely been integrated into diploma and Bachelor of Nursing curriculum, which I'm sure that you're all aware of with most institutions, using multiple modalities, including low and high fidelity simulation, such as part task trainers, mannequins, 3G, men, virtual reality, and simulated participants as pictured above. However, within the Allied Health and Community Services departments, low fidelity role play, lacking authenticity and realism, is most often employed as a preferred teaching method. During my master's research last year, I investigated the use of SBE in Diploma of Community Studies courses across Australia, specifically in regard to communication skills with vulnerable clients. My findings were that there was a significant disparity with the quality of literature supporting SBE for undergraduate medical and nursing, far exceeding that of literature for other healthcare courses. That SBE in nursing and medical undergraduate courses is prioritised over allied health and community studies, with infrastructure such as dedicated simulation centres, resources and expert staff being supported by influential professional bodies. And although clinical proficiency is directly proportional to communication skills, there's been limited opportunities to develop these skills in courses other than medical and nursing curriculum. So a master's research identified there is scope in Australian allied health and community studies to address a challenging healthcare workforce need, so that in collaboration with the Allied Health Department and pathology educators, we began to implement a SBE model between pathology students and diverse clients, with the aim to immerse the students into an environment contextualised to their workplace, highlighting therapeutic communication skills, inclusive of empathy and rapport building, and strengthening student learning in this healthcare field. The SBE model embedded the UNACSL standards of practice simulation design and followed the 6 stages of immersive simulation. A simulated participant playing the role of a vulnerable client was employed and prepared for their role. A pilot trial was conducted and a 3.5-hour SBE was rolled out to a cohort of students. The communication-based simulation was offered to all students in the Cert 3 Pathology Collectors course and was not an assessment component, having no impact on a student's grade or progression throughout the course. It was important for the students to be aware that the SBE was designed to replicate what they would be expected to experience on a clinical placement, and that there were no tricks or traps. As this was a first immersive simulation experience for the learners, it was really important that a comprehensive pre-brief occurred, including discussion of rules of engagement, safe learning environment, confidentiality, goals, objectives and expectations of the SBE, orientation of learners to the simulated environment, the simulated participants and the equipment, and the process to contact others during the simulation, including the use of timeout and safe words, and also provision of time for participants to prepare before the start of the simulation experience. Whilst one student volunteered to be an active participant with the simulated patient, the other students became observers of the immersive simulation, seated in our theaterette, which was with one-way glass looking into the simulated apartment. Objectives for observer roles were discussed, and the use of observer tools were explained to hone judgment of performance compared to standards and promote inclusion of the observer's perspective to debriefing. Our SP played the role of Ella Brown, a Year 9 student at a local high school who lives at home with her parents and 2 siblings. Ella is an active teenager, however requires a blood test as she's been complaining of tiredness and lack of energy and finds it difficult to concentrate in class. In this frame, we see the client, Ella, being greeted by the learner, practicing therapeutic communication skills, non-verbal communication skills, such as eye contact and body language, ensuring Ella's at ease and comfortable, and all her questions were answered appropriately. The role of the learner was to perform a vacutainer method of collection, caring for the client from the moment they enter the facility to when they leave, with all documentation completed and infection control guidelines adhered to. Ella enters the clinic using the Service Victoria app to scan the QR code. Medicare processing, correct identification, explanation of the procedure, and obtaining verbal consent was a really essential component of the procedure. Asking further questions to fully understand the client and any potential issues. Much venipuncture practice is done in laboratory sessions. However, role-playing between themselves of various client situations occurs, with the most likely situations they're perhaps going to encounter. So although venipuncture is a minimally invasive procedure and relatively low risk, there are considerable clinical risks associated. So learners need to be aware of the risk factors, the signs and symptoms, and how to reduce these risks to the patient. And when complications can occur, the learners need to know what to expect and deal with any complications that may arise. In this frame, we see correct labelling of blood tubes, which is a mandatory compliance requirement, where the student needs to clearly verbalise client details and ensure the client positively confirms personal information is correct. As a qualified pathology collector, it's important to adhere to infection control, waste disposal, and sharps injury prevention and management. There were technical components of the simulation, including application of the tourniquet in the correct position, palpation and selection of the appropriate vein, swabbing the site, anchoring the vein, and warning the client of needle entry. However, what the student was not expecting and had minimal experience was a client, Ella, exhibiting signs of increasing anxiety, as we can see in this frame. As the scenario continues, Ella expresses signs of anxiety and is offered the option to lay down on the bed for the venipuncture by the learner, who provides reassurance with a calm, professional demeanour. With Ella exhibiting strong non-verbal communication and venipuncture refusal, the learner is required to listen actively, clarify details, and practice the use of open and closed questions to gather information and obtain specific details to assist her with the scenario that was unfolding. With Ella's anxiety showing no signs of decreasing, the learner recognises the need to abort the procedure, problem-solving reasons as to Ella's anxiety, actioning and recording details, all the time providing reassurance and empathy. Prior to this immersive scenario, client refusal was touched on in previous learnt theory. However, the learner had not experienced firsthand this constraint and barrier in communication, and how to subsequently address and resolve the issue in a practical environment. The learner, however, demonstrated excellent communication techniques in the unfolding scenario, discussing various options for Ella and offering her access to a more experienced collector if Ella desired. However, Ella did not feel ready for the procedure and requested she come back at a later date for another attempt. Throughout the scenario, the learner was able to practice her moral and legal obligation to ensure the safety and well-being of Ella, her client, and perform her job according to sound technical ability and good judgment. Ella left the clinic feeling safe, heard and validated, leaving the student to clean her environment and prepare for the next client. A positive ending occurred, even though the venipuncture did not occur, with a different and enriching experience for the learner in this immersive scenario. A comprehensive debrief occurred immediately after the immersive simulation, exploring the learner's experience of the simulation and their perspectives on the learner's objectives and outcomes. We had feedback with the educators and peers. However, the most valuable feedback that they hadn't experienced was the feedback from the adolescent SP. She provided the learners with unique and valuable information about their actions and behaviours and how this affected the SP's emotional experience, the SP's trust in the student, and the understanding of the information exchanged. Thus, the SP's feedback filled a really critical educational role in the learner's interpersonal communication skills. A focus on what the learner did well and what could have been done differently using a simple plus delta Pendleton debriefing method was used to encourage reflective learning. Students' evaluation was overwhelmingly positive, highlighting the realistic and immersive attributes, rating the immersion simulation as so much better than role play with each other. Other student evaluation discussed the overcoming of communication barriers, practicing words that the young client understood to make the communication effective. By witnessing anxiety and emotional state that can cause a breakdown in communication, learners discussed how the use of plain language and effective non-verbal communication assisted the development of a respectful relationship, even though the original aim of a blood collection was not obtained. After analysing evaluations, learners from the Cert 3 pathology course overwhelmingly reported their knowledge and communication skills benefited greatly from the immersive simulation. Further key findings reported students identifying gaps in their knowledge and feeling much more confident and less anxious following the scenario, with more confidence to interact with real clients after contact with the SP. Participants also self-reported SBE with the simulated participant was an effective strategy to increase their confidence, conducting conversations with clients before they are facing a real life situation. After such positive evidence for immersive simulation within the non-nursing and medical healthcare undergraduate student cohort, simulation at Holmes Glen has continued to explore the new healthcare scenarios, including the story of Jimmy Chen, a chronic oversharer who faints during blood collection. Other scenarios within the dental department, community services and allied health have been developed and implemented with great success. We've come so far in our journey at Holmes Glen, and it is here that I give thanks to the shared knowledge and support of colleagues within the faculty who've been willing to think outside the box to produce innovative educational experiences for our students. While the holistic human impact of COVID-19 on all of us cannot be underestimated, navigating uncertain futures has allowed us to respond to COVID-19 innovatively with unique and at times unexpected opportunities to try new things. To all of you listening today, I hope you found my presentation somewhat informative. I wish you well for the rest of the day and look forward to now relaxing and listening to the other speakers. Thanks so much for listening.
Thanks, Melissa, for such an engaging narrative. So we'll come back for questions at the end. So participants, feel free to post those into the Whoever app. So now I'd like to welcome our second presenter, Greg. So Greg Connolly is an experienced occupational therapist at Mater at Home. You might like to start loading your presentation, Greg. He's recently been appointed as Allied Health Education Coordinator at Mater, and he is working to embed a link between the Allied Health team and Mater Education. And today he's presenting on his translational simulation project addressing COVID home visit safety for home visiting services. Thank you, Greg.
Oh, thank you so much for that introduction, Jenny. I'll just bring this up to share with everyone. Okay, good morning everyone and welcome. I'd like to share my small contribution with you towards keeping staff well in Queensland. Yeah, it's a real privilege to be here and to share the forum as well with Melissa, Ann and Philip. I think I speak for everyone. I want to say that I just simply can't wait for Jimmy Faints to come through. My project is concerned with COVID safety for home visiting staff, and the primary tool is process testing simulation using our OptiSim program for Mater. I'd like to start by asking you to think about this healthcare scenario. So a pathology collector is performing a standard collection in the community. He has a busy schedule and which has been arranged by his call centre. While taking bloods, the patient reveals that she's suffering from several symptoms which may indicate that she has COVID-19. The collector has never encountered a suspected case and has no COVID-specific PPE. The collector suggests that she contact her GP and leaves the property. He's now concerned about spreading COVID to his next patients. He's worried about the patient's well-being and he needs some urgent advice on how to proceed. He then calls his manager, who learns that the patient was not asked about her symptoms prior to the visit. The manager is aware that without a proportionate response, the collector might spread COVID in the community. The other clients may be denied services or key opportunities may be missed to test patients. The good news is that these risks were identified under simulated conditions using our OptiSim program before any patient or staff member had been exposed to them. My name is Greg Connolly. I'm an occupational therapist based with Mater at Home, Allied Health Education Coordinator. But this year I completed a fellowship with Mater Education with a focus on COVID preparedness through OptiSim. So it is a real privilege to be here to showcase how we identified gaps in our service using simulation to test our processes and also to improve the outcomes for staff and the community. We define OptiSim we describe it as a process of optimization through simulation, which is a technique used to replicate real-life guided experiences in a fully interactive manner and in a safe environment. Now, as you can see from this infographic, there are many arms to the OptiSim program. We'll be focusing today on the systems testing aspect over to the side here, and I'll focus on that in a minute. While planning my project, I was able to look at the COVID response within Mater. The demand for OptiSim has only increased through the COVID pandemic, including testing the COVID vaccination hubs around the state. Other examples of OptiSim happening up here in Queensland were to do with the testing of the Springfield Hospital before it opened. So real process testing focus. I noticed with regard to the COVID response here at the Mater, there were several OptiSims that had been conducted on the hospital campus. For example, patient flow. So when transporting a patient from emergency to ICU, for example, the testing ensured that the infectious patient could be tracked and isolated from the hospital population with appropriate PPE and cleaning resources made available, but also realised that no equivalent testing had been undertaken for home visiting services. Like anywhere in the hospital, this is a space where healthcare workers were at risk of actual harm and the organisation at significant reputational risk if not managed correctly. In the community, basically, clinicians have limited access to incidental advice and support. As opposed to hospital ward, clinicians are often required to bring significant amounts of equipment along with them into the home, which represents a risk of cross-contamination from one visit to the next. I was curious, what would our response be if a clinician suspected that they had been exposed to COVID in the community? Is there a process and is it effective? Within OptiSim, we employed the systems testing tool, as I said earlier. This involves stress testing systems and processes through simulated scenarios to highlight any active or latent safety threats, barriers to full functionality, and inefficiencies in workflow and communication. Our process allows us to take work as imagined, replicate the real-life scenario by bringing these procedures to life, and provide recommendations to effect change to optimise the response. I conducted a tabletop walkthrough of expected outcomes with the managers of home visiting services, and we identified an existing process which had varying degrees of uptake and compliance. Essentially, when arranging a home visit, efforts would be made to determine the patient's COVID status, including on the day of the visit before entering the patient's home. The health worker would have sufficient PPE and infection control equipment. Should they suspect exposure, the health worker would contact the responsible supervisor, who would provide reassurance and clarity to the health worker by referring to the existing COVID probability and screening tool, which you can see here. If indicated, they would then arrange for a discussion between the health worker and the on-call infectious disease consultant. So we realised that our staff actually had access to, direct access to industry leaders, or including Dr. Paul Griffin himself, which obviously provides a high degree of assurance and confidence in the quality of the information and direction you're being provided with. The consultant can then provide direct advice on next steps based upon the factors presented, including the patient's reported symptoms, proximity and environment, and importantly, the current health advice. We took clinicians through the scenarios as they would in real life or as close as possible in the simulated environment. Then all the participants were able to provide feedback to identify risks and recommendations. Today, I'd like to explain the 4 scenarios which we tested, to share some of the bumps along the way, and importantly, the outcomes and the perspectives of the participants. The first simulated service was MARTA at Home Allied Health. We included a few elements to ensure the appropriate degree of realism. Might be hidden behind this, but as you can see, typically the simulation suites which we use are focused on medical procedures. So there are oxygen outlets and such. So we provided coffee cups and couches, but importantly, we included entering and leaving the property, and accessing the vehicle and returning to the vehicle as well. So it took place over several locations for each of the simulations for that degree of realism, including inside the hospital and in the in the car park, basically. The clinician is the participant, fulfilling their actual job role. The actor was a member of faculty, and the observers included service managers and directors. During the scenario, the participant is able to actually phone the patient, the manager, and infectious disease consultant who made themselves available to receive the calls. The first simulation took place in March this year. You may recall from around December onward, the COVID response had been relatively scaled back due to the low prevalence in the community. Nobody was even much required to wear masks back then. So it was ironic when the COVID-based simulation needed to be delayed due to a COVID outbreak and lockdown in March. We got there in the end. In this scenario, the physiotherapist is visiting a patient with a respiratory complaint, which served to mask several of the symptoms which were known on the previous screening tool, which is being reviewed here in the vehicle before entering the property. As in all the simulations, the patient reveals that they're lacking a sense of smell, which triggers a response from the clinician. As the simulation played out, the clinician was unable to contact the infectious disease consultant at the first attempt and didn't pursue this any further, which resulted in a lack of clarity in their response, or certainty in their response, rather. That lockdown highlighted the importance of liaising directly with the consultant, because although the screening tool provides guidance on reporting, it's not able to advise on actions and a large variety of factors which need to be considered. The response during the lockdown, for example, would be different to the response 1 week earlier, and will now be different again due to the Delta variant, reopening of the borders, and various factors. Subsequent simulations showed that by leaving a message, simply doing that, the consultant would always return the call within a few minutes. So this was widely communicated. The infection control requirement to wipe down all equipment at the start and end of each visit was revealed to take less than a minute, but access to resources was inconsistent, with clinicians raiding the vehicle's infection control kit and depleting it for the next person, or removing items from the vehicle cab. As a result, in consultation with the infection control manager, a high-frequency infection control basket was tested and has been rolled out, along with a new work instruction to validate this procedure. The hospital and the home nursing service provided in-home IV antibiotics in this scenario. The existing infection control processes and resources are well established and fit for purpose, with a well-stocked kit, though we all agreed it was worth parking as close as possible or considering using a trolley, due to the amount of equipment which is standardly brought into the visit being quite bulky and burdensome. As a result of the simulation, a hard copy of the probability and screening tool was included in each patient's chart for their direct reference. As the HIF patient is technically an inpatient, the simulation raised the possibility of the nurse returning to the home to take a swab if this was agreed with the consultant. This actually led to a separate COVID-specific PPE kit being packaged and made readily available in the department to make that a possibility. When reflecting upon the simulation, the nurse unit manager who was present was impressed with the clarity and the chain of information which established that the infectious disease consultant are ultimately responsible for providing advice. When hospital and home were affected by an outbreak in Ciardulli here, which affected a lot of health workers and is a good example of not knowing who is and who is not infectious, the nurse unit manager instantly understood the process and could confidently and efficiently address the issue. In the maternity home care program, our midwives conduct health screening tests in the community. Our infant was crying quite a lot through this Bluetooth speaker, which hindered the COVID screening questions and the communication, and also lengthened the midwife's exposure in that enclosed space. Most importantly, the simulation helped to structure the response to the screening questions, as in how to provide services if a risk is identified. Midwives are increasingly offering telehealth for this reason and are more confident in its use. Staff are now more inclined to check their health information and screen for COVID because they know that they'll still be able to provide timely services in this way. It's also helped that during COVID, more patients became comfortable with accessing the internet for video calls. So the midwifery unit manager reflected that the simulation helped to embed these processes. Questioning is part of what they do, and this had to start somewhere. Also, as midwives had opted to selectively carry in equipment individually from the vehicle rather than bring everything in a bag, they're also issued with pocket alcohol gel dispensers once they learned that they were available, which was a surprisingly popular outcome. Now, back to the scenario I described in the introduction, with the collector taking 5 vials in close proximity to the patient. The pathology director who was present as an observer reflected that had she not attended the simulation, she wouldn't have realised that the screening processes were simply not part of the procedure in the community. This was alarming considering how strictly they're observed in hospital or hotel quarantine, where collectors will completely change their PPE between each floor. Attending the simulation meant that the directors could see work as imagined compared to how work was actually done. Although the collector had followed the standard operating procedure perfectly, the lack of screening for COVID required urgent action. Now, the call centre asks the questions, as does the collector when they're at the door. Another outcome was that the patient would be advised to ask their GP to refer to Mater Pathology community collectors for their swab, meaning that not only would the patient not need to leave their home, but the collector would not need to rely upon public health to advise whether the patient was infectious, hence reducing the time in quarantine. Simulation allowed the managers to communicate better with staff about the seriousness of COVID so that they're aware of the importance of the peripheral issues putting them at risk. If something out of the ordinary happens, it is okay to reach out. The simulation gave the managers time to reflect, and the debrief afterwards allowed them to come up with responses to the identified risks. We described the outcomes as the communication process improvements, optimised infection control processes, improved engagement amongst staff, and providing leadership with high levels of assurance. Translational simulation has proved to be a valuable tool for process testing our health response in the community. Mater offer OptiSim externally to help organisations to review and optimise their processes, and more information is available through this QR code. Thank you, all these email addresses and online. Thank you for allowing me to share our project with you. I hope that this presentation has provided you with a sense of how we use simulation within health services beyond education and medical procedures. I look forward to the remainder of the conference.
Thank you very much, Greg. Lovely variety again, demonstrating the applicability of simulation for us. So we'll come back for questions after the next presentation. So participants, feel free to keep posting those in the Congress platform. Now though, our third and final presentation from Starr and Philip Chong. Anne and Philip are joining us from the Sydney Clinical Skills and Simulation Centre and are presenting today on a novel and dynamic application of simulation-based education to contact tracing training in a pandemic. Thank you very much, Anne and Philip.
G'day, my name's Anne. I'm a nurse educator at Sydney Clinical Skills and Simulation Centre. I've been doing simulation for a minute, a bit longer than that.
And I'm Phil Chop, and I am the lucky duck who gets to work with Anne at this sim centre. And Anne is a soccer enthusiast, which will explain the illusions in the upcoming slides. And we're here to tell you a story about how we became part of a successful adaptation of simulation-based education to the changing world of the pandemic. So our story starts here, and I'm pretty confident this picture needs no further explanation. So the COVID-19 pandemic caused much disturbance in our centre, as it did with many other operations in our lives, I'm sure. Many of our staple courses were paused, and while the healthcare community battled against the virus, we were left with a yearning to help, and help we did. We pivoted and innovated to meet the new and changed learning needs of healthcare workers. So our suite of courses morphed into COVID airway team training, systems testing for new COVID specific workflow processes, protected ALS training, surge training for staff to support areas of need like intensive care, and also virtualization of our existing essential face-to-face courses. And among all this, we came up with an idea to go straight to the eye of the storm. Given the volume and rapidity with which non-public health staff were being recruited into contact tracing roles as part of the surge response, and the concurrent overloading of public health staff at the time, we realized that there may potentially be an unattended learning need. So our centre has had a long established history of providing conversations-based education on many dimensions, and we saw this as a golden opportunity to collaborate.
Once the idea was born, our next step was to get in contact with our public health unit directly and identify if what we thought would be a potential need was in fact the case. And what came back quite quickly was, in fact, that yes, they were having issues in terms of orientation and supervision of larger volumes than they were used to the public health units of surge staff. So there was definitely a need and definitely a willingness to partner for us to develop a simulation program, specifically towards those surge staff who were coming new into the public health units. So we set about with our needs analysis, and from the offset we knew that whilst the conversation element is something we're very comfortable with, the specifics of the public health and particularly the contact tracing interview was something we didn't have experience with, so we needed to get a good grasp on what it was we needed to cover. So we set about doing a series of focused interviews with a large number of public health staff, including public health nurses, public health doctors, epidemiologists, and the experienced ones, as well as some of the staff who've been brought in the first few months as surge staff. And what we really wanted to know is what did they want from this program? So the participants walking out of this were the big needs. And consistently coming across it was a lot more confidence and awareness and skills of being able to manage these interviews. We also asked them quite specifically, what does good look like? And we really needed to get a feel of that ourselves, but also if this was something that we were going to be modelling, promoting in the course, that we had to have a good understanding of it. We also wanted to address some of the common issues or complications or difficulties with the conversations, and certainly a few things came back, and often the public health staff were getting on the phone and they were the first people to tell them you've got the COVID. So there was definitely an element of breaking bad news, and also managing strong emotions, which was certainly a concept we were not unfamiliar with, being something that we cover in our courses. So yeah, that was pretty much our needs analysis, which then formed our game plan. So we developed a core development team, and we worked very, very closely with the public health unit here, again, looking at what we wanted to deliver. Our primary focus here in terms of the orientation, which was where we wanted to pick up the staff and to be running this program, was that we would not be an all-encompassing course. So in terms of what does a public health unit do, that's a week-long course. We're not going to go into that. We really wanted to focus on that conversation element, and that would be the part we would play in their orientation and in a timely manner, so that we would be picking up the surge staff, which were coming in groups of about 6 to 8 in kind of 3-monthly intervals, and that we'd be able to pick them up within the first couple of days of them starting on. So with that core development team, we also wanted to be quite clear as well as what we wanted to achieve, and it was really about that rehearsal and having focused simulation. And that was a big focus of this course, which originally we looked at, a 4-hour program, but quickly realised it would need to be longer to make sure each of the participants had an opportunity to rehearse each of the elements of the conversation. So that was a big strategy of what we wanted to be achieving, and we will create scenarios and have our faculty playing the patients so that they could actually have that live interaction. The success of this program ultimately, I think, falls to the collaboration between the simulation centre and the public health unit. And very often you'll approach a group, or a group will approach us, we would like a course, fantastic, and off they go. And this project would never have worked or been as successful as it was had they not come with us along that journey in terms of helping us with the needs analysis, curriculum development. We wrote the scenarios. It was very important for us that those scenarios were realistic, as well as being able to meet the learning needs. Us reviewing those for us. We wanted to provide, again, examples of good, so helping us to produce audio recordings and examples of calls that could be utilised in the course. And then very, very importantly for each of the programs, given this is not, we are not the content experts, they had made an agreement that they would assist us on each of the programs and send at least one experienced public health nurse as the content expert for the programs itself, which was really very important.
And so through this extensive needs analysis and preliminary inception process, we landed on some key objectives to guide the course design. So in terms of content, it was identified that the course, like Anne was saying, would often be for the purpose of informing the case about a positive result or having been an unwitting close contact. The surprise or anticipation of the core often deteriorated into frustration, anxiety, and sometimes even anger. So good conversations effectively diffuse these situations methodically, compassionately, and calmly. It also came to our awareness that these calls had the potential to be lengthy and multi-segmented. It was important that the caller could effectively direct the conversation in a structured manner while still comprehensively completing a detailed trace. So we went about designing a course which would scaffold learning to each of these objectives prior to a simulated conversation with a case. We emphasized a structured approach to the handling and de-escalation of strong emotions and applying a structure to the conversation, including the effective use of previewing and parking, and a repertoire of aid memoirs that would help the case with recall. So the result was a 6-hour small group interactive course chunked into parts according to the conversational structure of open, body, and close, each with its own interactive learning session followed by simulations. The simulations allow the learners to practice, observe others, receive feedback, and also engage in reflection. So actually, since the writing of these slides, we have now delivered 9 of these courses with the fortune of having public health experts attend at each one of them. We're also delighted to have been able to offer each group of new recruits the course in a timely and opportunistic manner in the first week of deployment. And Anne will then continue to talk about the excellent feedback that we got.
The goals were hit.
Correct.
Hence the sucker slides. So I think when it comes to reviewing the course, there's probably 3 perspectives that I think are worth sharing. The first is that of the participants. Our participants are quite varied. So I think when they've initially done pandemic planning, the idea of surge staff or public health units have been, we'll take on retired doctors, and the reality of what they actually got was quite different. And they got a wide range of staff. So they were looking at new graduate nurses, experienced nurse unit managers, dentists, dental hygienists, occupational therapists. So there was a wide and diverse group coming to these courses. And again, there was a lot of nervousness. So a lot of the people that we dealt with had done no contact tracing at all. Some of them were studying their public health at the time, but hadn't actually experienced it. So one of our main objectives had been confidence and unanimously, hard word to say, that was something that was reported back to being something quite valuable. So our participants said that the course was excellent, they found a great value in it, and that they felt a lot more prepared to the next day to getting on and starting to conduct the interviews. The other perspective that's quite useful is that of the public health unit staff who are involved in both the course development and the course running, and also dealing with the staffers, the surge staff as they hit the deck. So again, the feedback throughout this process has been excellent, and probably one of the most useful things I've found as a feedback is when one of the nurse unit managers has actually said, this is so realistic, this is like a day at my work, which is really what we set out to achieve. We didn't want to give them an unreachable standard, we wanted to give them standard and ability to rehearse that in a safe space. Also would follow up with the nurse unit managers probably a week after the course around that point to see how they're going. And again, at that point, they said it's just fantastic. And some of the added benefits they added in there, which again, we thought was quite nice, was the course also provided a bonding experience for those new staff who'd never met each other. So they would often have lunch together in a COVID-safe manner, I hope. But it also gave them a resource moving forward in terms of their development and people they could reach out to. And they'd also met the public health nurses on the course and created a bit of relationship with them. Last perspective would be that of our staff and myself, and certainly I walked into this project with a bit of trepidation and probably focusing more on what I didn't know than the skills we had around conversation. But the way that we formed this course and the way that we ran it, it is actually a pleasure to run, a privilege to be able to assist public health units throughout this pandemic. And our faculty, who have included nurse educators, fellows and consultants, have come on board and all equally really enjoy running the program and can see the connection between our normal conversation courses and things we do clinically and the public health course. So there was definitely a good match and very well reviewed. So I guess there was some limitations, and again, some of these are by design, but certainly have some limitations for potential future courses. So given that our course capacity, the course was designed for a maximum of 6 to 8 participants. And again, by design, we really wanted to have that time for rehearsal and the ability to kind of repeat and everyone to get an opportunity to rehearse and observe each part. So we break into, again, smaller groups, and therefore with that comes a greater faculty requirement. So our faculty requirement for that group size is 4 faculty, and in addition, the public health expert. So the faculty is quite high compared to the participant numbers. At one point, we were approached to potentially run this program for 80 medical students. And again, that really took us back to the drawing board as to what we could offer and how we could offer it, given that we feel the big value here is that smaller group working ability to rehearse. But some of our future modelling, should that be required, is that there could be online components, breakout rooms. It would still be quite faculty intensive, but certainly that would probably be the biggest limitation. Unexpected discoveries. So I think for me, the biggest light bulb moment has been previously when we think about simulation, and certainly a lot of our programs are postgraduate, critical care based, teams based, conversations based. I've not previously thought too much about running this for other units such as public health unit, and certainly the applications are huge and wide, and we have a fantastic relationship with the public health unit. So moving forward, we're ready to go should they need another course or get more surge staff. We have done our modelling for larger participant cohorts should we need to. From this came the approach for us to start developing a program for the virtual hospital staff who are being deployed there to be able to manage COVID patients in the home. And I think certainly this shows us future applications for conversation-based courses in the wider health community. I think that's us.
That is us.
Thank you.
Thank you very much. That's excellent. So we now have the opportunity to ask all of our presenters from this session some questions. So if I get all of our presenters to start your videos again in a virtual panel, and I will moderate the questions. I'm going to start with a question from Melissa, if you're there, please.
Yes.
Yeah. The question is, how did you identify the key features at the right level of challenge for your simulated scenario?
Sorry, I'm just trying to get my video.
That's okay. We can actually hear you. So.
Sorry, can you repeat the question?
No worries. The question is, how did you identify the key features that needed to go into your simulated scenario to provide the right level of challenge for those learners?
Yes, we actually started by consulting with the pathology teachers, and we actually worked off an assessment that they do to be able to move their students on to the next lot of education. So we had a three structured process as to what the students were requiring to do throughout the simulation, and from there we looked at the assessment and then worked out a way that we could approach this from a simulation based methodology instead. So
did you then work with those educators again as you developed up the scenario and the scripting of that scenario?
Yeah, absolutely. So the educators had no idea how to write a scenario. It was all very, very new for them. So we had some workshops where we spoke about the aspects of simulation, how to write a scenario, how to conduct a scenario, pre-briefing, debriefing, etc. And from there, the educators played a very vital component in the scenario. So we would meet quite often. I would show them the point that I was up to and some of the thoughts. Because I'm not a pathology collector, I'm a registered nurse. I didn't have an in-depth understanding of their processes. So they were really valuable to give you that information. As far as that's not quite realistic, that wouldn't really happen. How about trying this? If this was to happen, we would do A or B rather than do C. So there was a lot of validation and within the pathology collectors and the educators, and also within the simulated participant as well. So we would give the script to her and say, well, as a teenager going for a blood test, how do you think that you would react to this? Is this something that you think is going to be appropriate as a 15-year-old girl going for a blood test and having these anxiety issues? So there's a lot of collaboration within the scenario, and then also during the pre-run, we had a lot of opportunities then to look at how we were going to do it and change aspects of the flow of the scenario so that it was going to be the right approach for our students. So we seemed to hit the nail on the head, which was great.
Excellent. A good indicator that your collaboration has gone well. Thank you. A question for Greg, please. You described a great application of simulation there for process testing and improvement, and you talked a bit at the end about the value to the managers. What was the impact on the participants who were doing their everyday jobs as they were kind of participating and being observed by those managers with perhaps less than optimal procedures at the time?
Yeah, that was something that we were very careful to address in the pre-brief. So just to manage the expectations of the participant, to reassure them that they had, that they were not the one being tested. It was really the process which was being tested, and that they, took particular time out to have fairly lengthy discussions with them around that. It wasn't necessarily their direct manager. Sometimes it was the director of the service, which, you would imagine could be quite nerve-wracking. But yeah, I think that the feedback that we received afterwards, because they all got to participate in the debrief afterwards, was that because of the pre-brief that we'd done, and because it was a collaborative, no fault type of setup, that made it quite successful, and ultimately a really collaborative experience where everyone was able to contribute their thoughts.
Thank you. Excellent. I think reinforcing some common messages I'm hearing across the Congress about collaboration and also the importance of those pre-briefs and debriefs. A question for Anne and Phil, please. You also were collaborating. You were collaborating with different teams as you developed your scenarios and your education package. Has that collaboration had any ongoing impacts on your work at the centre beyond this particular program?
I would say so. It's something we're quite used to doing with all of our programs anyway. Collaboration's quite integral, depending on the programs we run. So we work with a lot of different services. I think probably from my perspective, the biggest impact is that there are potential collaborations beyond what we have historically looked at. And I think that's probably the biggest message that we would have. So we work quite closely with a number of different stakeholders, both within our area health, but also different colleges and groups. So yeah, I think it's a positive note, and certainly going somewhere that was unfamiliar became quite comfortable. So a positive thing for us moving forward. Yeah.
And do you have anything to add, Phil?
I would just echo what Anne said, in the sense that it was somewhere that we wouldn't have looked for the potential for simulation prior to the pandemic, and it took the pandemic to focus our attention that way for us to even see there to be a potential collaborative partner there.
Necessity being the mother of invention, they talk about. I think that a lot of things have arisen out of COVID, so thank you for your sharing. If any participants want to drop any more questions into the chat, we do have a couple of minutes. There is a question, please, for Melissa. Sorry if we missed the detail here as you were presenting, but did each learner participate in the scenario, or was one learner observed by a number of others? And either way, what, if anything, did you note of peer learning through the use of such a realistic simulation scenario?
Yeah, so there was one learner that volunteered to participate actively in the scenario with a simulated participant, and the other learners were their role was observers in our theaterette with the one-way glass. The learning was incredibly valuable, though, for everyone. I think sometimes there's an understanding that if you're an observer, the learning experience isn't as valuable. But as it was such an incredibly realistic, immersive experience, all the observers rated their experience as incredibly valuable and powerful, because they just had never had this experience of working with a simulated participant or someone that was they didn't know, let alone an adolescent simulated participant. So usually they would do role play. They would say, the teacher would say, okay, today we're going to pretend that you're going to faint or pretend that you're anxious. They would giggle amongst each other. I think when you've got that this fellow student with a role play, it's not taken as seriously, whereas this, and being in our immersive simulation centre, which the students had never been to before, was such an incredible experience for them as well. I think for me, I've seen the nursing students take advantage, have the advantage of being in the immersive simulation centre all the time, and you sort of you get used to, I guess, the experience that they're being offered, and students probably do too. But for these pathology students who had never stepped inside our immersive simulation centre, had never seen a simulated participant before, it was all such a fantastic experience for them, and all the feedback was great. The only feedback that was negative was that we could perhaps have done more scenarios or had a longer period of time. So we do plan to rotate students through, but this was very much a pilot program for us.
Excellent. This question I'm actually going to direct to each of our speakers, because you've touched on it in different ways. So the question is about, this whole session and all of what you've been presenting is about responses to COVID-19. And so the question is about how quickly we can adapt and roll out some of these things. So we've heard Greg's spoken about multiple scenarios, Melissa's talked about multiple storylines, and Anne and Phil, you've talked about a detailed needs assessment process, but then where you're heading next. So I might invite Greg to speak first, please.
How quickly can it be rolled out? Yeah, that's a really good question. Before I commenced my fellowship, my colleague had started with, I think she had been appointed before the advent of COVID. She found that in her fellowship, she was, pretty quickly co-opted into participating in many COVID-related simulations. It more sort of monopolised her first 6 months, I think. But within a very short amount of time, the internal processes were reviewed, particularly like I mentioned in my presentation about patient movements, patient flow within the hospital, and that was actually rolled out really quite quickly. And so I was quite surprised at how that was done, and I think that a lot of this feeds from the previous experience of having within MARTA, within Optisim, having previously tested a whole new hospital before it was rolled out. So it was very much in the way that things were done. So yeah, it can be done quite quickly. Mine took place over, I suppose, a longer period of time due to, I suppose there was just myself involved in that project, but it evolved and developed as it went on. So it was all done in a timely way. But yeah, it can actually be done really quite quickly, and I was surprised as far as that goes.
Your thoughts, Anna and Phil? You obviously had quite a detailed needs assessment process, and I think there's a lot of value in that. I don't think the question is necessarily implying that quick is the optimum thing, but about being responsive.
Yeah, we did have a detailed needs assessment process, but we were ready in literally 2 weeks. So certainly what this pandemic has shown us with all of our courses is literally our programs got shut down. We're like, what are we going to do? And suddenly we were having to prioritise on a weekly basis the work we were taking on. And like the hospital, things were changing quickly. They were changing daily. And to be able to produce courses in the time that we've never really done that before, had such a focused effort. And certainly what was happening in the hospital in terms of the changes there, the protocols changing. So I think probably from the pandemic as a whole, it's shown me the resilience of the healthcare community as well as the simulation community in meeting those needs. what can be achieved when we really put our minds to it. Yeah, I think things can be done a lot quicker. They can still be done well. But yeah.
And I think we also were able to lean into the experience that the centre already had in building courses in a rapid fashion or semi-rapid fashion. And also, as we were saying, we had started to build a suite of courses in response to the COVID pandemic. So we were getting at the hang of actually building courses in almost in a bit of an improvised way.
Yeah. And we added something that we did, which we previously hadn't done for some of our courses, was actually rolled them out at the trainer-trainer method, which was not for this course, but potentially could have been. That was a really good model as we got the senior staff come and do this course, take it with you, go do it on your units. So that model was actually really very useful and got large numbers of people through training quite quickly.
Excellent. And I think, Melissa, was it just a very quick final comment, was it very similar for you in that collaboration rolling out and transferability between those storylines, I guess?
For me, it was pretty much a whole lot of luck that I had identified this need in my master's research the previous year, and we were already thinking about collaborating with allied services and pathology to get this on board. So the most difficult time was actually timetabling. So we've had numerous lockdowns in Melbourne and long lockdowns. So trying to get that window of opportunity where it was safe to bring our students onto campus to deliver the simulation face to face. Other courses such as a nursing, we were pivoting to online SP work. So it was pretty much just luck and perseverance that got us there in the end.
Okay. Thank you everyone for your participation and great insights on the responsiveness of SIM. So we've got a morning tea break now, and Deanna Hutchinson is also hosting an action station on ethical issues for policy and practice. So you can join the community section for that. Otherwise, we'll be back with parallel sessions at 11:15. Thank you very much.